Hello. Good evening, everyone. Good evening, speakers. Good evening, listeners. We have got listeners here, as I see, from all over the world. We'll start with our symposium today on the options in the surgical management of prolapsed lumbar intervertebral disc. And at first, I will invite the Secretary of Neurospinal Surgeons Association of India, Dr. Selvan, to give an introduction. Dr. Selvan, please.
Hello, sir. Good evening to all the participants. I'm extremely happy to welcome you all on behalf of the Neurospinal Surgeons Association of India. Namaste. This is a seasonal welcome gesture because of the COVID pandemic. Many thanks to our professor and our mentor, Professor Ramani, who has started the webinars, and he's making us all active even during this lockdown period. And this is our second webinar, and the topic is surgical management of prolapsed lumbar disc herniation. We had our first webinar last week on 18/4/2020. The topic was on lumbar canal stenosis, and we had nearly 700 participants who took part in that webinar. Today, I welcome the speakers, Dr. PG Modha, Professor P S Ramani, Dr. Yang from Taiwan, Dr. Arvind Kulkarni, and Dr. Sumeet Pawar. And finally, I request all the participants to raise your questions in the chat window and addressing to the concerned speaker so that it will be answered promptly at the end of the session. Thank you and welcoming you all.
Thank you, Dr. Selvan. Thank you for that introduction. And before I proceed further, at this point of time, I would like to thank INTAS, particularly the ITMA division, for their technical assistance that they are giving to us to conduct these webinars, which have proved to be very, very successful in terms of education and the way the participants are listening to our webinar from all over the world. It gives us extremely pleasure to proceed further. With that, I will now request Dr. Prakash Modha to give his presentation on the pathophysiology of prolapsed lumbar intervertebral disc. Dr. Prakash Modha, please.
Yeah, good evening, sir. I'm Prakash Modha from Rajkot. I would like to share my views on the pathophysiology of the lumbar disc prolapse. Is everybody hearing me?
Yes, sir. Yes.
Lumbar disc prolapse is a condition which there is a outpoaching of the disc nucleus pulposus along with few annular fibers and end plates cartilage through the tear in the annulus fibrosus into the extradural space. Next slide. Once the disc extruded and degraded nuclear material impinging on the nerve roots, and nucleus pulposus is an immunogenic which induces an inflammatory response, which produce radicular pain syndrome and radiculopathy. With hedging, vascular channel starts to fail and vascular diffusion of nutrient decrease. Thus, the number of viable chondrocytes in the nucleus pulposus diminish. Synthesis rate and concentration of the proteoglycan decreases and proportion of collagen increases in the nucleus pulposus. As a result, water binding capacity of the nucleus pulposus decreases. Nucleus becomes more fibrous and stiffer. Nucleus is less able to bear and disperse the load. transferring the load to the posterior annulus, hence posterolumbar disc prolapse. Next. If you look at the epidemiology, the mean age between 30 to 50 years, males are more affected than the females. A most common level of the disc prolapse is L4-5, and after that L5-S1, and most common type of disc prolapse is posterolateral disc prolapse. Next. If you see the disc and nerve root relations, L5 nerve root at L4-5 level is traversing nerve roots, while it comes down and exits from the L5-S1 foramina, that is exiting nerve roots, and when there is a disc prolapse at L5-S1, it will cause impingement of the L5 nerve root, and if the disc is bigger, it will impede the S1 nerve root as well. Next. We'll see why disc prolapse is more common posterolaterally. If you see in this figure that this part of the annulus is weaker, its posterolateral part of the annulus is weaker, and there is less posterior support from the ligament, posterolongitudinal ligament. That is why when pressure comes, this part of the annulus gets tears and causing posterolateral prolapse of the lumbar disc. Next slide. If you see the etiology, the commonest etiology is to lift up the heavy weight, obesity, vehicular accidents, and smoking are the common causes of disc prolapse. Next, please. Now we will see the effect of smoking. Because of the smoking, blood vessels get constricted, transport of nutrient and disposal of waste products decreases. This cell get deficient nutrition or die. This degenerates and result in the disc instability. Why pain occurs on the affected side on raising the normal leg? When we raise the normal leg, there is a stretching of the dura and nerve roots. When there is a big disc prolapse, it gets rubbed with the nerve roots and causing pain on the affected side. Next slide. When we do the Valsalva maneuver, there is an increased pressure in the dural sac, which causes pressure over the disc and now gets rubbed with the prolapsed disc, causing sciatic type of pain in the leg. Next, please. Now we see that the key diagnostic points for lumbar disc prolapse is leg pain greater than back pain, neurological deficit may present, may not present, annual tear when you see, back pain is the greater than the leg pain, and bilateral SLRs are positive. Facet joints arthropathy, localized tenderness presents unilaterally over the joint, pain occurs immediately on spinal extension, and pain exacerbated with the ipsilateral side bending. So these are the key diagnostic points for the etiology of the lumbar disc prolapse. Thank you very much.
Thank you very much, Dr. Prakash Modha, for that very precinct, very informative, and very brief presentation of pathophysiology. I think that is what people who are listening must be looking forward to hear from you rather than the routine lecture type. Very good, excellent, Now, it is my turn to talk to you. The most common, what I call is a gold standard, I call it a minimally invasive spinal surgery, although in the world it is labeled as open as versus endoscopic. I call it a minimal invasive spinal surgery, microlumbar discectomy. If you notice in this webinar, we have not included laminectomy as a treatment for the prolapsed lumbar intervertebral disc. I believe that that is not the answer today for a given case of prolapsed disc. And if anyone is still practicing laminectomy for a given case of prolapsed disc, you should think it very seriously and change over to microdiscectomy or endoscopic discectomy. But today, there is nothing like laminectomy for a given case of prolapsed lumbar intervertebral disc, although it began with laminectomy. That is a different part in the evolution of the surgery of lumbar disc. 1973, 1974, 77, 78, Yasser Gill, Kashpar, Scoville, Williams. These were the pioneers we thought and started practicing microlumbar discectomy. My contribution, way back in 1987, I started doing this procedure. And since that time, I have never turned back, even today. I do it very regularly. And my incidence is about 120 procedures per year, on an average. Today, I have a follow-up of my patients lasting 10 years up to December 2017. What are the advantages of microlumbar discectomy? It is a procedure of choice for a given case of lumbar PIVD. Minimal retraction of the tissues. Microscopes give 3D magnified vision, and most importantly, very excellent illumination. Meticulous hemostasis, minimum handling of the nerve roots, and very effective decompression of the nerve root. That is what we are all here, whatever the methodology that we use, finally, we have to decompress that nerve root, which is causing sciatica. You must remember at this point that once you have removed the disc, it may be sequestrated also, and you are very, very happy, excising that and showing to your assistant, see, look here, I removed the whole disc in one piece or something. But go down inside again, have a look at the nerve root. There may be compression further at the level of the foramen or into the foramen itself, or when the nerve root is going out of the foramen. And unless you decompress that nerve root in this region through the same microscope and through the same instruments, perhaps patient may not be very happy. And that point must be taken home very, very clearly. It is a choice of procedures by micro approach. Microlumbar discectomy approach can now be used for other conditions also. For example, I use it personally, as I told you just now, for lumbar PIVD. It may be unilateral or bilateral, or it can be at more than one level, 2 levels, even 3 levels. Most important, particularly in countries like India, as age advances slightly, and when it goes above 45 years, lateral recess stenosis starts appearing, which causes compression on the nerve root from behind. And therefore, one is obliged even to remove that portion of the bone which is causing stenosis of the lateral angle of the bony canal where the nerve root is lodged. And then it can also cause foraminal stenosis, which needs to be addressed, as I said above, before finally concluding with the procedure. Many times, people who are working in the docks people were handling heavy machinery, were carrying heavy loads on their back, on their head, the spine is degenerated. And I see a degenerated spine even in young people at the age of 40. They have got tremendous osteophytes, and many times that osteophyte is impinging into the nerve root from the front. Just like disc is also coming from the front and impinging on the nerve root, even the osteophyte from the vertebral body, and mind you, these osteophytes are more common in the upper body than in the lower intervertebral body, and one can excise these osteophytes very satisfactorily through this method. What are the essentials? What are the essentials that you require to do a microlumbar discectomy? I do it under general anesthesia. Whether you agree with me or not, I do it under general anesthesia. My table, as you see, it is flat. It is not curved, it's not bent. I keep two bolsters, 26 inches long and 13 inches round. They are firm, but not hard. Patient is lying prone. I like Mally's bipolar coagulator. I use Esculap micro instruments, and of course, Dr. Ramani's microlumbar instruments, including microlumbar retractor, which has become viral in many countries in the world today. Next slide, please. The technique, when I started way back in 1987, I used to use an incision from 22 to 20 millimeters. Now I use 14 millimeters incision. It is paramedian on the side of the disc, 1.5 centimeters away from midline. Very meticulously, I do subperiosteal separation. I don't touch the muscles. There is no handling of the muscles. There is no dilatation into the muscle. There is no whatever sort of injury directly to the muscle fibers. Muscles are not handled. Excision of the lateral part of the ligamentum flavum lying on the nerve root. It is not necessary to remove all the ligamentum flavum, only the lateral part which is lying directly on the nerve root. Identification and then gently medial retraction of the nerve root, excision of the prolapsed portion of the disc. Then look at the foramen. You can do foraminotomy, and if necessary, if there is lateral stenosis, then you can do IDSS. What you require after that is meticulous hemostasis, followed by closure with couple of sutures to the skin. Surgical microscope, first. I use Carl Zeiss Pro Magis saline suspended 300 millimeters objective microscope. But now I use Carl Zeiss OPMI Pantero 900 with 3D monitor and the recording, next generation in magnified vision. Doctrine. My doctrine is that use of operative microscope has made PIVD minimally invasive spinal surgery with minimally invasive techniques. Minimally invasive techniques. Microlumbar discectomy was popularized by me as a standard procedure in India and many parts of the world. And these are the microlumbar retractor, which many of you know has been approved by the WFNS and WFS and Spine Committee both. Next slide. the dictates. The blood loss is only 20 ml or so. Operating time varies between 50 to 55 minutes. I use, whether we agree with me or not, 2 doses of 1 gram of cefotaxime, 1 dose before and 1 dose after surgery. There is no shaving, no catheter, and no Redivac. Age, as Dr. Prakash Modha said, 31 to 40, maximum, with another maximum curve coming at 41 to 50. Sex, of course, there is slight preponderance of the males. And type of work, of course, person who is working with mobile all the time. Plus, as I told you earlier, those who are doing heavy duty work, these are the people who are most prone to get prolapsed lumbar intervertebral disc. Inclusion criteria, presence of sciatic pain is very important, positive imaging, failed conservative treatment, early neurological deficit, and single level disc prolapse. Next. Exclusion criteria, history of previous surgery, failed back, psychosomatic disorder. Pattern of cases, my personal experience, L4-5, Dr. Prakash Modha showed that is very common, 46%, followed by L5S1, 42.8%. Level of disc prolapse, as you see in this chart, posterolateral and the sequestrated discs are the most common patterns at L4-5 and L5S1. Observation on level and age. This is very important. Not many people have appreciated this point, but fifth PIVD is common below young people. Below the age of 25, fifth is very, very common. If a boy of 12 years or 13 years come to me, I know he has got a fifth lumbar disc prolapse. Fourth is common between 25 to 50. And third is common above the age of 50 years. Range of symptoms, duration before they come for surgery. This is a very, very common knowledge. You all know it. 12 weeks to 2 years in our country. Mean is 5.81 months. Common people usually now in cities like Mumbai, they come within 3 to 6 months and opt for surgery. Next slide, please. Operative technique, IDSS, principle of IDSS. See, this is the portion of the bone that needs to be removed so that the nerve root is quite free into the lateral angle of the bony canal. Now, you expose the ligamentum flavum. And what I do, I take 15 number blade and incise the ligamentum flavum vertically without injuring the dura. Then I put a cottonoid so that the dura is protected, and I cut the lateral part of the ligamentum flavum as shown here. Yeah. Now, cutting the disc, what is the principle? You have to cut the annulus like a piece of cake and excise it. And here it is. You see here, the nerve root is gently retracted. You cut the annulus like a piece of cake, and the disc is there, which is prolapse, which you can remove. Never feel happy with that. Put your forceps inside this way. Any loose piece must be excised. Now, cutting the osteo, I talked about osteophyte. If there's an osteophyte from the upper body, this portion needs to be excised. I have with me a set of micro osteotomes varying between 1.5 millimeters onwards. This is the upper body. This is the osteotome. The nerve root is protected, and you can see very clearly the nerve root. And then that osteophyte is easily excised, as you see it here. Post-operative instructions, Silver's criteria, muscle strengthening exercises, early work resumption sedentary, within 2 weeks, hard manual work within 6 weeks, riding two-wheeler after 4 weeks, but four-wheeler they can ride within 3 weeks. 97.5%, and that is the figure everyone in the world must remember. If you are doing alternative procedure, you should produce better results. Next slide, please. This is Oswestry disability score, my results. Next slide, please. Complications, not many complications, very minor. And this is comparative analysis of complication by various authors. It's only Williams, way back, first he started in 1978, he had about 9% complication, but later on, after 10 years, his also complication rate has come down. So on an average, complication rate in various end can vary between 0 to 4%. Recurrences. In my series so far, I had 13 patients. Of these 13 patients, 4 patients, there was a technical fault, technical mistake. They were not discharged, but I went in again, reoperated, and then sent in. Now, if you delete these 4 patients, then the true recurrence rate in 9 patients, which comes to our 1.7%. Recurrence rate of mine is 1.7%. Next slide. These are various authors in the literature, and they have got recurrence rate anywhere between 3 to 4, etc. Criteria, you know this criteria very well: excellent, good, fair, poor, how you analyze your patients. And the grading, again, as you know, well, fully recovered, almost recovered, some pain in the back, and not satisfied. Yeah. Evaluation outcome, 89.33 plus 7.97, that calculates the figure I told you earlier. Next slide, please. PIVD. Due to stress on the adjacent joint, ASD, I have encountered in my series up to 2017, 5 cases, 5. Period, when they come to you, between 5 and 10 years after the first operation. Interestingly, all these 5 cases were ipsilateral and at the upper level. Number of no patient with contralateral recurrence, and they were all associated with lateral recess stenosis, and that is how they require to be addressed. I operated all of them. I have done discectomy and I have done IDSS. Evaluation done by 2 experienced surgeons, 6 weeks, 12 months, 24 months, 60 months, and 10 years then. Long-term result, I showed you already. This is the figure. one has to achieve if you are using any other alternative method. In conclusion, ladies and gentlemen, microlumbar discectomy, whether you call MIS or whether you call open, done with 3 division, has minimum morbidity, quick relief from pain, early discharge from the hospital, and quick return to the original work, make it a state-of-the-art surgery. I personally feel it is a gold standard operative procedure today, to which other techniques are to be compared with this technique. Thank you very much for your patient hearing. Thank you. And now I will invite Dr. Yang, is it? Are you ready, Dr. Yang?
Hello, yes, I'm
Yes.
ready. Yeah.
Now it is your turn to give your presentation. Huh? You have 30 minutes, half an hour to present your work and your experiences. People would like to know that you have got your own simulator and you are demonstrating students who come from all over the world to you on your own simulator, which gives tremendous technique knowledge to the students. Dr. Yang, please.
Okay, thanks, Professor. And let me introduce myself. I'm Dr. Chao Yang from Taiwan. And so it's my pleasure to have a web conference with all of you. Actually, this is my first time to join the web conference. Please forgive me for the mistakes, and I promise that next time that everything will be much more perfect than this time. And now I'm trying to present my surgical experience of endoscopic surgeries for lumbar spine intervertebral disc herniated. And now we are doing another technique, not different from the German system technique. And we just start our endoscopic surgeries from 2000. And of course, all of you now knows that from the open surgery.
So please start sharing your screen.
I'm sorry?
Please start sharing your screen. Your presentation from desktop.
I'm sorry?
We cannot see your screen. We cannot see your presentation.
You cannot see your screen?
No. We can see you very clearly, but please start sharing your presentation as well.
Can you see the slides?
Share screen from the desktop.
Share screen. I'm using my mobile phone.
Yeah, and on the desktop when you are logged in, start sharing screen from that, your presentation.
Where?
The center green button, sir. You're on the Zoom app, right, sir? On the desktop.
I don't know. I don't know how to use it. Can you see the PowerPoint files?
No. You have to again start sharing screen. When we had stopped sharing screen in between, so now again you need to start sharing screen on your desktop.
I'm sorry. Let me.
When you move your cursor, on the center there is share screen option, green button.
Share screen.
Not on the mobile, on the desktop.
Oh, not the mobile phone. Okay, just a second. Share screen. I'm sorry, I cannot find the button.
Prashant, please help.
Kishore, Prashant, can you help?
Prashant.
So on your desktop, in the center of the screen, when you have your Zoom app as on, right?
I cannot find it. I'm sorry.
So when you move your cursor in the center of the screen below, lower part center.
No, I cannot find it.
Sir, there is a upward green color arrow in center next to the chat window.
Share screen.
Is your Zoom app open, sir, on your desktop?
Share screen. Just a second.
Yes,
Can you
perfect.
see this?
Yes. Yes.
Can you see the
Yes,
Can you
sir.
see the PowerPoint?
Yes, now we can see your PowerPoint very clearly, sir. If you can start from the beginning, then
Oh, sure. Okay.
yeah,
I'm
yeah.
sorry.
Yes, perfect.
Okay,
perfect.
then and let me restart my presentation. I'm sorry for that.
No,
And
fine.
of course, that we, from the beginning, we do the spine surgeries, from the open surgeries, open laminectomy, and pedicle screw fixations, and of course, micro endoscopic surgeries. And now we just proceed to endoscope surgeries. And of course, that now we have wolf system and joint max systems to use, and that there's the progress of the endoscope surgeries. And we all know that the inside out technique and outside in technique that different from the YAS technique and the thesis technique. And that is the anatomy of YAS technique and thesis. And we all know that we do the transforaminal approach, we would remove some part of the superior articular process and try to move our endoscope to go into the spinal canal to remove the pathology. And the indications that's different between the YAS technique and thesis technique. And of course, then right now we do the thesis technique, and we have much more widened indications to do this operation. Now that's for indications much more broader than the YAS technique. And as you know that we do the surgical approaches from interlaminar approach and transforaminal approach. And that's the difference between the traditional surgeries and minimal invasive surgeries. And of course, that the blood loss may be much more minimized, and we can do the operation under local anesthesia, and hospitalization day will be much more shorter than traditional surgeries. And in Taiwan, that the payment is self-paid, not the government insurance provided, and the recovery period is much more shorter. And we now just do the surgeries. We use the interlaminar approach, and not only for lumbar spine, and also for cervical spine injury, especially the foraminal stenosis cases. And that's our approach. We use the interlaminar approaches in cervical spine cases. And you can see that we can identify the upper and lower margin, and just remove the disc from the interlaminar approach.
माझ्याकडे थोडा अडकतोय तुम्हाला थोडा अडकतो माझ्याकडे थोडं थोडं ना हा थोडा लॅग आहे
And this is for another case. And we use the power that can remove part of the disc, part of the lamina from outer and lower border of the lamina, and to go into to remove the ligamentum flavum, and use the Carrison to step by step to remove the lamina. And this is a transforaminal approach. Sorry. And this is another case. And now we gradually remove the ligamentum flavum step by step, and to remove the herniated disc. So for another case, that's all for a transforaminal approach, and you can see that we always see the dura pulsations, and then it's the ending of our operation. That's we remove the herniate, the ligamentum flavum, and you can see the dura. And now I'm just introduce you that this our new technique. That's the most important for this presentation. That we can, as you know, that the most difficult part of the transforaminal approach to do the lumbar spine surgeries will be the reaming procedure. And most of the surgeons to do the ream procedures just by the patient's feelings, by surgeon's feeling, and under the CM under the CM image, and of course not so much hospitals can afford the navigation system. So when you do the ream procedures, the surgeons must be afraid of the injury, the patient's nerve root, or directly penetrate into the spinal canal to injure the dura. And now we just design a new technique for the Unitech technique, that we can remove our facet joint directly, and under the directly vision to remove the superior articular process, and just totally different from the traditional German technique. You can see that there's a ring just outside our just put outside our endoscope, and we can see what we are reaming directly see through the endoscope, and to remove any part of the structure of the spine, just like superior articular process, or you want to remove some part of the pedicles. So for this technique, that you can prevent the incidental injury to the dura, and then you cannot see directly what you are reaming, during your ream procedure, and that make your foraminoplasty procedure much more safe. You can see it again that. The endoscope is inside and the ream is outside, and we can see what we are reaming right now. So it's much more safe. You can see what you are reaming, so it's much more safe to prevent the incidental injuries. And I think that for this technique, we can prevent any incidental injuries when we are doing the foraminoplasty. Okay. So thanks for your listening, and I'm so happy that we just start our new technique for almost 50 cases, and now that for when using the new technique, we can decrease our radiation exposures when we are doing the foraminoplasty, because we can see what we are reaming, so we don't need to check from the C-arm again and again, and for the whole surgical procedure is much more, the time is shortened, and the patient has a good result. And for this 50 case, we do not have any incidental injuries when we are doing the foraminoplasty procedure. So I think that for this technique, and it's worth to learn it, and to make that makes our operation much more safe. Yes. So thank you for your listening.
Thank you very much, Yang. It was a very interesting lecture, and it's not a question answer series, but I just want to highlight one point. The endoreamer that you use, it is your own invention, correct?
Yes. And Professor, you know that when we do the endoreamer is just penetrate through the endoscope. But for the endosurge procedure, the reamer is outside the whole endoscope. We don't need to penetrate through the working channel of the endoscope. It's just in the outside, just in the outside part of the endoscope. So we can read much more bigger than we use the endoreamer.
Yeah, very good. Very good. Okay, thank you very much. Thank you. Okay. And now I will invite Dr. Arvind Kulkarni. He will be talking on tubular microdiscectomy using microscope. Dr. Arvind Kulkarni, please.
Yeah, good evening. Can you, Sumeet, can I concur with you? Can you see my screen? Okay. So, Dr. Ramani, Dr. Sumeet, thank you very much for this opportunity. So, discectomy is a very commonly done surgery. The way we do using these tubes is similar to Dr. Ramani's technique. Only thing is the retractors are different. Instead of the standard Ramani retractors, we use the tubular retractor here, through which we operate. These tubes come in various diameters, ranging from 18 to 12 millimeters in diameter. So we have highlighted our experience in these two big books. One is from the NSSA and one is from our Minimally Invasive Spine Society of India. For example, this particular lady, she has a BMI of about 40 and she's extremely stout and obese, as you see. And she was having significant, it is actually L4-5 level. So she was having significant anterior thigh pain going down to the shin on the left side, and terrible pain. This pain did not settle with all kind of analgesics, two root blocks given at that particular level. The reason being, this particular disc herniation is extraforaminal, and extraforaminal disc herniations, they irritate the ganglion, and this ganglion is extremely sensitive. So in spite of giving the best analgesics in the world, she was having annoying pain, and ultimately we had to operate on her, in spite of trying to avoid as much as possible, because those who have gone through a paramedian Wilsey approach would agree with me that it is a very daunting approach. So going through the paraspinal muscles, trying to get your anatomy right and localizing the disc, especially in an obese lady like this, it is a gruesome procedure. That is where these tubular retractors become handy. So once your localization is right, you pass these dilators. I'll be showing how to pass these dilators in the next few slides. You keep these passing these dilators of increasing diameters, and then we put your final port through which you operate. And this is the tube, and this is the superior facet. This is the transverse process of L5. As soon as you dissect this corner between the superior facet and the transverse process, you will see the disc. It is the lower part of the Cambine's triangle, and that so this video is not playing. The reason being, when we checked it out, it was not playing. I have other videos which I'll be showing in the next few slides. So that once your anatomical localization is absolutely fine with these tubes, it is a matter of 15 minutes that the disc herniated disc pops out, and that is the kind of relief that patient gets is immense, and the morbidity of approach is hardly anything. You can see the size of the scar here. So that is the beauty of minimal access. So these, I call them the old workhorses: the Cobb's retractor, the mastoid retractors that we use, the way we expand this potential space, retracting the important paraspinal muscles and causing scarring and traction on these muscles. So that is circumvented with minimal access. So compared to our own colleagues in different specialties like general surgery, urology, etc., it does appear that when you use these instruments shown in the previous slide, we are quite ancient. So that is where these tubes come in. So they are our workhorses. So there is no real space to get in, unlike the abdominal or a pelvic cavity. There is no open space in spine. So we need to create space. So these dilators create a temporary port through which we operate. So they come in, this color coding is for the diameter. So this parrot green is a 16 mm diameter tube, and this dark green is a 18 mm tube, and these numbers, they denote the length, the depth. So here it is 4. So that means the depth of the tube is 4 centimeters. So I'll show you a procedure here. So this patient has a large disc herniation, if you see here, and he has significant right-sided leg pain, which has failed conservative treatment. So as I remarked earlier, the surgery is the same, which Dr. Ramani described. Your localization has to be perfect. That is the spinolaminar junction. You should be able to see the flavum. So you need to do a laminotomy, then excise the flavum, and then reach the disc space. So this is how the tube is parked. Sumit, can you see the video? So this is the initial guide wire. It is passed paraspinally in the range of 0.8 to 1.2 centimeters from the midline, depending upon the size of the patient and the level which you are operating. Once the guide wire is confirmed, the guide wire should be collinear to the disc, and these dilators go on top of the guide wire, and the level, the localization is checked on C-arm. So the disc should be collinear, the tube should be collinear with the disc, and the disc should be lying in the middle of your tube in a straightforward disc herniation. So that is how the tube is docked. Once the tube is docked, it is fixed to the railing of the table using a flexible arm. And this is how the surgery is done. So this is the head end where my arrow is, and this is the tail end. So this, you see, is the lamina. So good quality microscope is very, very important. So this is the lamina. So this is where the facet joint complex is. So you need a long cautery tip, and then a good quality burr. I use a cutting burr, 4 mm diameter. So you see the outer cortex, the inner cancellous bone, and then the inner cortex. So depending upon your experience and confidence level, you can use, narrower diameter tubes, from 18 to 16, 16 to 14, and with experience, even a 12 mm tube. So you can see how beautifully the microscope helps us, define each and every layer of the anatomy. So microscope is very, very important, as Dr. Ramani highlighted, because every structure here is in different shades of white. The bone is white, the flavum is relatively white. It is called a yellow ligament. In elderly people, sometimes it's quite white, especially towards the midline. The nerve root is bluish white. The intervertebral disc is white. Then, so it's very important that you have good magnification. The PLL is white. So once you create a slit in the flavum, you keep excising the flavum and come laterally. The flavum is away from the dural sac, more towards the center. So you start from midline and come towards the lateral part. So you see that disc. So once you insert your nerve hook, which is a very important instrument, the disc, herniated disc, pops out. So that is the herniated fragment. You need to appreciate the beauty of this surgery. You need good quality instruments, right from the instruments. I mean, including the microscope, a good quality C-arm, a good quality burr, a good quality nerve hook, and a good quality pituitary. Everything should be of an optimum quality. So you gently separate the dural sac as well as the nerve root from the disc and pull it out. Most of the times, in one piece, the whole thing comes out, but, never say never. You should always check all the potential spaces where you can miss the disc. That is in the axilla, the upper part of the shoulder. Usually, by reading the MRI, you know where the disc and disc fragments lie. And it is optional whether you put some amount of locally acting steroid or not. It is supposed to work on the C nerve root, C nerve ending, so the C fibers. So that is the procedure, and this is our initial report of the first close to 200 cases that we did in 2013. It has a cosmetic appeal, as you see here. Again, interleukin 6, CRP, they all rise after any surgery, any traumatic procedure, including surgery. And it's been shown that with this particular procedure, the degree of morbidity is quite less compared to the standard open or micro discectomy procedure. Again, it is safe because the tube will restrict your degree of retraction. This is the beauty of the procedure is, if there is a superiorly migrated fragment like here, you don't have to localize your tube on the disc space. You localize it right on the disc and then make an oval hole through which you can excise the disc. That way you don't have to do a this is an inferiorly migrated disc. You basically tilt the tube inferiorly, just like the way you tilt the tube superiorly when there is a superiorly migrated fragment. So this is what I was talking about. If there is a migrated disc, you don't have to go all the way to the lamina and keep doing your laminotomy. You just make a hole using a drill, and you remove the disc. So you're not playing around with the anatomy, and thus the stability of the spine. So these are the steps you can see. It's a hole which is about 6 to 8 millimeter in diameter, through which once you localize perfectly, you can remove the disc fragment. So this is what we published. So this is of use in migrated discs. So you localize the tube exactly on the lamina where the disc is herniated, make a hole there and pull it out. And again, similar to endoscope, you can pass the tube in a patient who is unfit, where patient is not going to take a big burden of fusion surgery. Patient has a lot of comorbidities. If we are suspecting discitis, you can push the tube in and remove all the material from the disc, send it for biopsy, and as well as culture, and you give a thorough wash of the disc. This helps in giving some pain relief as well as getting good culture of the disc. Again, in recurrent disc, especially when it is migrated down, you can go to the lamina above or below and again make a hole and pull the disc out. You can do 2-level discectomies with one incision, like here. Very rare for 2-level disc herniations to become symptomatic, but in cases with stenosis, it is quite common to have 2 levels, L3-4, L4-5 or L4-5, L5-S1, both levels being involved. And by just tilting the tube in the superior inferior direction, you can do a 2-level recompression. Again, in recurrent disc herniations, if you localize your tube appropriately, you can remove the recurrently herniated disc. Again, in selected cases of high lumbar disc herniations in chorda equina, the beauty of the procedure is, the length of the incision remains the same. The depth of the tube might change depending upon the thickness of the patient, but the skin incision is the same. So this is a big boon in obese patients, where we keep digging the paraspinal muscles to reach the lamina, especially in huge patients with a high BMI where the spine is extremely deep, such as this particular patient. It makes life extremely easy. Initially, initial practice, you might find it difficult to deal with situations like this with central disc herniations, but over a period of time, with experience, by learning how to position the tube in the right place, you will be able to do these central discs. Sometimes the tube is forgiving. I would discourage anyone to do this, but this is what we did. This patient had a herniation on the left side. By mistake, we went on the right side. But since you can tilt the tube, go on the opposite side corner and remove the disc, we were able to do that. But I would not suggest it. But in case you got lost and in case you have good amount of experience, this is something that is possible. Again, the beauty of the tubular retractor is once the tube is removed, the paraspinal muscles just fall in place. It is like a tamponade effect. So if you have a dural tear and a CSF leak, if you just take a watertight suture, it can be forgiving. You don't have to worry about the dural tears. That is because unlike an open surgery where it is like an open bucket, here it is an inverted cone. So the possibility of CSF collecting is too less, minimum. And since the tube, till it is docked in the right place, you're taking shoots one after the other. The possibility of doing a wrong level surgery is hardly there. Again, patients with poor skin condition, where you don't want to take big incisions because we are worried about wound healing. This is a boon. Again, the infection rate with these tubular retractors is close to 0 in uninstrumented cases, because the exposure in the surface area that is exposed to pathogens is less compared to open surgery. Again, with experience, as I said, you can minimize the size of your incision. So now we generally use a 14 mm tube. These are experience with a 14 mm tube. Again, this. So this is a patient where patient had a old L4-5 degenerative lysis for which she was not symptomatic, but had a left-sided L5S1 disc herniation for which she presented acutely. In spite of conservative treatment, she didn't get better. So we did a L5S1 discectomy. This was done using a 14 mm tube. Again, large fragments can be excised with a 14 mm tube. This is an extraforaminal disc, similar to my previous speaker. You can go extraforaminal using these tubes and excise the disc. So this is a 12 mm tube which was specially made by Medtronic for us, because we had a good handle and experience with a 14 mm tube. So we got a bit greedy and pushed in for a still narrower tube. And using a single stitch, we can do this discectomy. So this is a video. The steps are the same. So that is the flavum. So you need to have a good orientation, and you should have experience with, in working in closed channels, which is not difficult for neurosurgeons. So once the laminotomy and flavectomy is done, the disc just pops out once you put your nerve hook in. So in straightforward cases, we have been able to do this discectomy under local anesthesia also. For example, in this particular lady who had a L5S1 disc herniation, you can see she's awake and she's able to talk with us when we are doing the discectomy. So in a straightforward, easy case where you'll finish the surgery in about half an hour, 45 minutes, we give this dexmedetomidine, and as we go down, we keep injecting a local anesthetic. So here I'm chatting with the patient while I do. So with experience, you can narrow the diameter of the tube, and again, the narrower the tube, the less collateral damage that you create. So in the context of comparison of techniques, if the same degree of decompression and symptom relief can be obtained with lesser tissue trauma and morbidity, then that particular technique, which is most minimally invasive, would qualify to be adopted. So that is the basis behind using narrower tubes. So I think with this presentation, you have a better understanding as to how a tubular retractor can be used to do a discectomy. It has various other indications, applications like lumbar canal stenosis, doing an interbody fusion with bigger tubes, excision of synovial cysts, revision surgeries, etc. The advantage is, surgical goal can be achieved using less iatrogenic trauma with less pain and less complications, and early reintegration of the anatomy and as well as physiology. And as I said earlier, because of its various other applications, it's a very versatile instrument that one can use. Thank you very much.
Thank you. Thank you, Dr. Arvind Kulkarni. Your voice was very clear and loud. Your slides were good. And everybody got the message very clearly from your lecture. It was very instructive. Thank you very much.
Thank you, sir.
Yeah, so now I will request Dr. Sumeet Pawar to summarize today's webinar on surgical options for lumbar PIVD. Dr. Sumeet Pawar, please.
Yeah. Thank you very much, Dr. Ramani, for giving me this opportunity to summarize the talk. We have gone from the pathophysiology of how and why the disc herniation occurs, the most common levels, the most common typical demography of the patients. Then we have seen Dr. Ramani speaking about the gold standard, the workhorse, the basic of treatment of intervertebral disc herniation. We have seen the microlumbar discectomy, the procedure that he has introduced in India and popularized by holding our hands and teaching us how to do it. And then we have seen Dr. Yang speaking about the endoscopic management of disc herniation, the surgeries that he's doing totally under local anesthesia and having an excellent, equally good result. He's doing the endoscopic procedures via the transfemoral route as well as the interlaminar route that we are very used to. And now we have seen an extremely versatile tool, tubular retractors by Dr. Arvind Kulkarni. He has popularized this technique since a very long time in India and has shown the versatility, the utility, and everything of that technique in this talk. I will be giving a short summary of the talk over here. I don't have anything much to add, but just the surgeon should know what they have seen and the main differences in the three techniques. The muscle dissection in microlumbar discectomy, as Dr. Ramani has said, is subperiosteal dissection. It is good in a way that the muscle is not damaged directly. We are only lifting up the muscle and retracting it. Problem is with the insertion over there, which the muscle splitting is said to be better. Everyone says that their technique is better, that we have to accept that the muscle splitting, once the blood supply is not affected, the muscle, there is some pain because of the splitting of the muscle, but otherwise the attachments are still intact. Instruments are, what routine instrument you are using is same that you are going to use for microlumbar discectomy. There is no specialized instrumentation that you require for it. If you have a good Ramani retractor that I mentioned over here, that is a workhorse. That is going to take care of most of your lumbar cases. In tube, the tubes are used to retract the muscle, not Ramani retractor. In endoscopy as well, we have a small working channel, which is basically a tube from which your endoscope is going to pass. Endoscopic discectomy requires a completely specialized set of instruments, which are usually 3 to 4 millimeter in diameter, which are very thin, flimsy, may break frequently. In tubular microscopic discectomy, its similar instrument can be used, but they usually need to be bayonet shaped so that it don't come under your vision if you're using a microscope. If you're using tubular microlumbar discectomy using an endoscope, like we had seen in the EasyGo system last time, it does not matter. You can use any routine instruments. The visualization with microlumbar discectomy is using a microscope. In tubular, you can use an endoscope or a microscope, whereas an endoscopic is, of course, and you use an endoscope. Size of incision, it varies as per your expertise. Dr. Ramani has just mentioned that he is using hardly a 14 millimeter incision. Dr. Arvind Kulkarni has mentioned that he is using a 12 millimeter tube. So as your expertise increases, the size of incision keeps on going lower and lower. Endoscope basically has an incision of 7.5 to 8 millimeter. I don't think it makes very big difference the size of incision outside, because in the end, what you're doing inside is what matters. Cosmesis is of course important, but few millimeters here and there is not going to make a big difference. Anesthesia, on the other hand, makes a big difference. Endoscopic discectomy can be done totally under local anesthesia. On the contrary, PLD should be done under local anesthesia because that is working as your nerve monitoring in PLD, and interlaminar as well, as seen with Dr. Yang, that he is doing totally under local anesthesia because the procedure hardly lasts for 20-25 minutes. So there is no much discomfort. You can talk to the patient and patient can go home within 2 hours of surgery. Tubular, I had no idea Dr. Arvind Kulkarni is doing under local as well. That's very impressive. Otherwise, usually they're done under GA only. What does the research have to say about comparing these three techniques of whether we should be doing microlumbar, tubular, or endoscopic? The first question is, should we operate or not operate? I don't think that's a big debate over here. Surgical versus non-surgical treatment for patients who deserve a surgery. I'm not speaking of patients who are just in acute disc herniation, but usually a low quality evidence suggests that surgical treatment is more effective than non-operative treatment in improving physical functions. No significant difference was observed in the adverse events. This needs to be noted over here. This study from 2014 from European Spine Journal, where they had done a systematic review and meta-analysis where they're comparing what we are discussing, interlaminar minimal invasive discectomy versus microlumbar discectomy, that is tubular versus microlumbar, and PLD versus microlumbar discectomy. A very good study, including 16 RCTs and 13 non-randomized studies. About 4,400 patients were studied, and they have moderate to low quality evidence that there is no difference in the clinical outcome between microlumbar discectomy and minimal invasive surgery for patients with sciatica due to lumbar disc herniation. More studies are required. Every conclusion you will find that there are more RCTs are required. There are very few differences here and there, 11 minutes longer, 52 ml less. It doesn't make big difference, according to me. This study from 2018, it compares PLD with microlumbar discectomy in Korea. It's a good meta-analysis, and they have about 1,200 patients they have studied. They have shown that while percutaneous endoscopic lumbar discectomy, please note, PLD shows better result than open lumbar discectomy. The open lumbar discectomy results are still equally good. They're slightly better than that, not significant. So to really prove a superiority study, we need a bigger study. Larger sample would be required. This World Neurosurgery paper in 2018, it compares all the things that they were discussing: tubular discectomy, percutaneous endoscopy, and microlumbar discectomy. This meta-analysis says that tubular discectomy and percutaneous endoscopic discectomy are most commonly employed MIS techniques for discectomy. They are safe alternatives. If you note this line over here, microlumbar discectomy is associated with significantly lower incidence of revision surgery. This one thing caught my eye because resurgery is an accepted problem in minimal invasive techniques. Due to inadequate decompression, we don't know where to stop. As compared to microlumbar discectomy, we have much better control because we are seeing much bigger in front of our eyes. And this study from 2017, which compares 7 surgical interventions, a network meta-analysis of very good 3,100 patients, it has shown that PLD might be best choice to increase success rate and decrease the complication rate, but microlumbar discectomy is the best option if you want to drop your reoperation rate. So that's something to note. To summarize my summary, microlumbar discectomy is gold standard, least reoperation rate, lesser complications. MIS techniques like PLD, tubular discectomy, or interlaminar endoscopic discectomy, PSLD, have better clinical outcomes, less blood loss, less stay. Everything is slightly lesser, significant, not significant. They have slightly higher complication rate and reoperation rate. You have to choose what is best, what is feasible, what is suitable for your practice. If you're doing microlumbar discectomy, you can be a master like Dr. Ramani and do from 14 millimeter incision and still have a fantastic result. You have to be expert in whatever you are doing. Which technique really doesn't matter. Thank you so much.
Thank you. Thank you, Dr. Sumeet Pawar, for that wonderful summarization of today's webinar. It was very instructive, very good. For the viewers, I would like to say that we will be putting this webinar on the YouTube. We are in the process of editing. Once it is well edited, once you put on the YouTube, you just cannot put everything on the YouTube. You have to edit and put it. We will definitely put it on the YouTube, edited version, and then we'll definitely make a message that everybody, all this, your data, by the way, is collected by us, and all of you will be informed that we are putting these webinars on the YouTube. Now, this webinar is open for discussion, and once again, I would like to thank the technical team brought here by the Intas pharmaceutical company, Ultima division. I thank all of them for taking all these pains to make this webinar possible for us. As far as the questions are concerned, there are too many questions. I have to be a little choosy, but first, a very important question I would like to ask all the speakers, take their opinion. But first, I will come to Dr. Yang. Dr. Yang, can you hear me?
Yes, yes.
There is a question here. A young spinal surgeon is starting his surgery. We should start doing straight away endoscopic or not? What is your opinion?
I'm sorry?
Young neurosurgeon, young
Yeah.
surgeon, spinal surgeon.
Yeah.
He's starting his practice.
He's starting practice
Yeah.
endoscopic surgery. Yeah.
No, he's starting his practice.
Yes.
He has just passed out from the university and he wants to start his practice.
Yeah.
So he should start doing endoscopic, microscopic, or open first to just get the practice of familiarity with the tissues. What he should do?
Actually, Professor, sorry, I cannot understand your question. I'm sorry.
Dr. Yang, Dr. Ramani is asking.
Yeah.
The participants are asking that in the beginning of their career, should they start with microlumbar, then tubular, then endoscopic, or do you recommend that even a beginner should start with endoscopic directly? A young neurosurgeon or a young orthopedic surgeon, what do you recommend?
My recommendations for the young neurosurgeon or young orthopedic surgeons.
Yeah. Yes.
If they want to start the endoscopic surgeries, my suggestions. Actually, I think that not everyone surgeons that can practice endoscopic surgeries very well, and actually that I think that I always tell my fellowships or my medical students they have to learn how to practice the open surgeries first. They know the anatomy first, and when they are so familiar with the open surgeries, and they can try to practice the endoscopic surgeries. But first, they have to go to the cadaver workshop and to learn from the cadaver and to see the experienced surgeons to do the endoscopic surgeries for at least 20 to 30 cases. And when they start the first case, they have to one experienced surgeons stand beside the young surgeons and help him to practice. Once he or she face the problems during the operation, and for at least practice for 20 to 30 cases, and he can do the endoscopic surgeries alone. Yeah, that's my suggestions.
Thank you. Dr. Arvind Kulkarni, would you like to answer that question?
Yeah, it's a very important question because the fellows and residents here at their wits' end as to how to. They see several procedures and they don't know what to pick up. What I've seen with my experience is, if you worked with a mentor, you get convinced with the technique that he uses. and over a period of 2 to 3 months, you will get a hang of it. You see the same patient getting benefited, in the follow-up OPD, etc. And in the operating room, you're learning those techniques. So I have seen that, whatever technique you learn from your mentor, that is the best technique.
Thank you. Thank you, doctor. You want to say anything else, Kulkarni?
Yeah, and again, see, for example, the tubular technique that we use, unless you have, first of all, you should be a good open surgeon first. You should be able to know the exposure. You should be able to bail yourself out when you're stuck in any step of surgery. Second is, you should be able to use the microscope well. You can't buy the tubes, you can't buy the microscope at the same go. You should have good experience with using the microscope. Then, subsequently, once you buy the tubes and you work with someone who's a master in these tubes, then things fall in place.
Yes, thank you. Thank you very much, Dr. Kulkarni. Personally, I also agree with Dr. Kulkarni one thing. He used the word mentor, and that is a very important thing when you are doing your post-graduation, whether it is university or national board, it does not matter. When you are practicing, there is always one mentor where you are working with all the time with these procedures. You have to watch him very, very carefully. Whatever you don't understand, you have to write down on the notebook. And once he has finished the operation, you should tell him to explain this to you if you are sincere about it. Then, as Dr. Yang said, very important, this is the time you should go to the postmortem room. You should do cadaveric dissection, get orientation with the structures. And once you have done that, most importantly, during your post-graduation itself, you must try to get as much micro practice as possible. All my residents, I always give them practice. I take them aside. I take aside the microscope. First, I put just piece of gauze piece. And I tell them to separate the fibers of the gauze piece separately under microscope. Then I ask them to take a cut on the glove, which we are throwing to the dustbin, and ask them to suture it. Then I also cut a piece of the rubber catheter and give it to them and ask them to anastomose it on all sides. All such practice with the microscope should be done during your residency, which you will never get once you pass out and go into your private venture or public venture, wherever you are there. I would say it's a responsible venture. If you go that way, I personally feel that whatever you have been expert with your mentor, you should practice that science, provided you have all this homework with you. Do you agree with me, Kulkarni?
Yes, sir. Yes, sir, definitely. Because there's no much difference between the techniques, unless you are doing a very morbidly, unless using morbid techniques to remove a simple disc. So most of the techniques are quite convincing, whether it is a microdiscectomy, tubular or endoscopic. So most of our patients do well, and you definitely get convinced. By the fellows and residents do get very much convinced by what technique the mentor is using.
What is the end point of this?
Yeah. Dr. Prakash Modha, brief one word on this issue.
Sorry?
Do you want to say a brief word on this issue that we are discussing now?
I do agree with you that during the residency, one should be accustomed with the microsuturing and microscope.
Yeah.
And they must attend the cadaveric workshop frequently. And by doing so, once they pass, they are able to start direct microlumbar discectomy if they are well accustomed with the microscope.
Wonderful, wonderful. Dr. Selvan, what is your comment?
So it is all God's gift to get a mentor who can direct us to the field which even we don't know how to select. Fortunate that we all got you and we are used up to microlumbar rather than any other instrumented technique. Maybe Sumeet Pawar is gifted to land up with young giants like Arvind Kulkarni and all to deal with all these sort of gadgets. But still I feel from my training period from Professor Ramani, microlumbar stays good and takes time for the youngsters to get themselves accommodated to the narrow field and micro dissection and limited workup place.
Yeah, thank you. Thank you very much. I will move to the next question here, and it is again very important question. What is the end point of discectomy in these procedures? And as far as I am concerned, microdiscectomy, the end point of the procedure is not just removing the protruded disc. I told you very clearly, check the lateral recess. If it is very tight, decompress it. And I told you very clearly in my lecture that having removed the disc, you must go check into the foramen. If there is any further constriction, stenosis of the nerve root, compressing anything there, or as the nerve root is going out through the foramen, is there, then it is decompressed. As Dr. Kulkarni mentioned, blunt hook, he said hook. It should be blunt hook, not a sharp hook. You take the blunt hook, put it under the root, and see that it is completely free from its origin till it goes out through the foramen. I have got a special nerve root probe, I call it, which goes into the foramen and out to see that that nerve root is free. And that I show to everybody. And at the end of that is my end point, then the nerve root is free. Kulkarni, what is your opinion?
Yes, sir. I think more than the pituitary forceps, it is the nerve hook which is a key instrument in this particular surgery.
Yeah. Thank you very much. Dr. Kulkarni, I would personally like to ask one question at this point. During your talk, you mentioned after the procedure, there is a rise in interleukin and CRP, correct?
Yes, sir.
Why did you mention this here? What was your reason of mentioning it here?
No, the thing is, when you compare the morbidity of each procedure, there is no objective measurement. So one of the metrics that you see is the rise in these particular enzyme levels. These are called acute phase reactants. So what surgeons have tried to demonstrate is that the rise in these acute phase reactants is much more less in minimal access procedures compared to open surgeries.
Yeah, thank you. Have you compared CRP and interleukin between various procedures?
Yes, sir, that's what that graph shows.
Yeah, that it is different, is it?
Yes. Yes,
yeah.
Sir.
Yeah, good. Dr. Kulkarni, I would like to ask, there is one more question here, and it's a very important question for us also. I'm very sorry to make this discrimination, but I have to make it here. We are neurosurgeons. You are an orthopedic surgeon. As days pass, I see more and more orthopedic surgeons doing PLIF, TLIF, whatever it is, interbody fusion for a given case of prolapsed disc. I do not agree and I do not do. I do not teach this technique to my students. But I see a lot of cases who come to me for one reason or another for consultation, and I see that he had a prolapsed disc and they have done fusion interbody fusion. You will be surprised to know that there was one ophthalmic resident who had gone to an orthopedic surgeon for a prolapsed L5S1 disc, and he had done 2-level interbody fusion. So what is your opinion on this question that is being asked here? I think it is probably asked by orthopedic colleague, because I see more and more orthopedic colleagues doing this.
Yes, sir. The thing is, my threshold for fusion is much more higher than neurosurgeons actually. And I'll share with you our paper, which is recently got accepted and it will get published now. We have I've shared this with you before also. For degenerative spondylolisthesis, we have developed a scoring system as to when to fuse and when not to fuse. So it is getting got accepted in this Clinical Spine Surgery, which is a premier journal. So my threshold is very, very high to fuse. The first thing I see after seeing the patient and the MRI and X-rays, dynamic X-rays, etc., is how much I can push myself to just do a decompression and get the patient better. So I tilt on the side of doing less and achieving more. Unless there is a very pressing need to fuse, for example, the approach is difficult. There is a large central bulge, central disc herniation, for which you need to do a very wide, laminectomy, facetectomy, and the facets and lamina of that particular patient are very small. So you end up destabilizing that particular segment to remove that entire fragment. So this is one unique situation wherein I would probably fuse. But otherwise, my threshold is very, very high.
Now, another way, thank you very much, Dr. Kulkarni, for your open opinion on this issue, which is, for me, I think at least looks very important. There is one more very important question. There is a patient coming, Dr. Yang, you also listen to it, If the patient comes with a central disc prolapse, what will you do? You will still do endoscopic discectomy? Huh? Okay. Yang, is Yang there? No. Okay. Arvind?
Yes, sir.
How do you answer this question?
Yeah, so this central disc herniation, the patient, it depends. Sometimes the fragment is slightly more on one side sometimes. So you can catch the disc, the tail of the disc from one side and pull it out in certain situations. In some situations where, you can go in the axilla and put in your nerve hook and pull the fragment down. Sometimes when the facets are very small, and the facets are sagittal in orientation, and the lamina is also small, the dimensions of the lamina are also not great, wherein when you do a laminotomy and a medial facetectomy, what you see is that there is a very thin amount of bone that is left behind. So those are the situations where I would fuse. But otherwise, if the lamina is wide, if the facets joints are coronally placed, either go in the axilla and remove the disc, or sometimes just even from the shoulder side, once you've done a wide decompression, you'll be able to pull the disc fragment out. So the other key thing is, as you keep removing the fragment, the dura becomes mobile. So with gradual pulling out of the disc, you can keep negotiating more medially and making sure that you've removed the entire fragment that has come out.
Thank you very much, Dr. Kulkarni. You have made a very, very important statement in your discussion, that to start with, don't get worried, don't get excited about the medial disc prolapse. Go laterally. Go laterally first. Don't go in the axilla, don't go in the shoulder. Identify it on the root, just gently retract it medially. And even if we cannot retract it medially, because if we think we are putting a pressure because disc is medially, you can do IDSS. If you do IDSS, you get enough space laterally first to approach the disc, remove the lateral part, non-herniated disc first, Once you do that, and then gradually you find what Kulkarni explained, you find going space. It requires your patience. As you remove more and more and not annulus, now nuclear, you can put your curved forceps inside, and if you remove the nuclear portion of the disc, it starts getting loose, and then the retractions become easy. Once your retraction become easy, you can go and remove more and more discs, and then use your blunt hook to find out whether the under surface of the dura is quite free. You agree with me, Dr. Kulkarni?
Yes, sir. Yes, sir.
Yeah. That is the answer. Any other question? One question we will take. Last one question. And there are many questions, but we'll take one more question. Last interesting. Which one?
What the spine conference? Spine conference. The video we can video. Will you put in the video on YouTube?
That I told you. Yeah, somebody is inquiring about a personal inquiry when he is waiting about our spine conference, Spine 2020. I told you last time also, somebody was inquiring. I'm very pleased to know that people are looking forward for this conference. We have, at least as of now, we have proposed to hold in January, mid-January. But we will be with you again. We'll let you know. And with that question, and with all this discussion, we have come to the end of this today's webinar. I take this opportunity to thank all the speakers, Dr. Yang, Dr. Kulkarni, Dr. Selvan, Dr. Prakash, Modha, etc. I think it was a very, very interesting webinar. And one last word from Dr. Selvan. Dr. Selvan, please. Dr. Selvan, are you there, Rajen?
It has been very. Yes, sir. Am I not audible?
Yeah, you
Am
are.
I audible, sir?
Audible.
So once again, I thank all the speakers for sharing their wonderful experiences. These sort of things engage ourselves during this tough time. And thanks to Professor Ramani for making use of our spare time interestingly in academic events. So once again, I thank the organization who have brought up with this sort of beautiful webinar. Hope this will be recorded and kept in
In-task.
circulation.
That was the in-task ultimate.
Yeah. I'll be contacting them. So once again, thanks to all the participants also for taking their precious time with this webinar. Thank you, sir.
Thank you. Thank you very much. Thank you. Thank you.